a pleasure, Sabine, who is here today. And yes, so Sabine is a physician, researcher, organizational consultant and coach. She's the chair of gender in primary and transmural care at the Radboud University in Nijmege in the Netherlands, and professor of sex and gender sensitive medicine at the University of Bielefeld in Germany. Her main research focuses the implementation of sex and gender related aspects at all levels of the biomedical continuum, from basic research to policy making. She was a member of the EU expert groups Gender Innovation 2 and Gender and COVID-19, and she's currently a member of the Medicine Committee of the German Research Council and of the Medicine Board of the German Medical Association, as well as the number of other societies and specialty groups in the field. So, Sabine, thank you so much for being here. We are all really looking forward to your presentation. Thank you so much.
Thank you so much. So, well, thanks for having me. Do you hear me in the background? How much more do we need to speak? Okay, great. Wonderful. So it's good growing up in Italy because you know how to speak loudly. Hi to everybody online. Also to the people who are following us from the beach. That is just, I had to say that. And the pointer is not working. Technology doesn't work. So I think we have to do this, no? Do we have to close it all together? Well, while David tries to figure.
Okay, now it works.
Oh,
yeah.
Okay, all right. As you know, my talk today is going to be about the impact of sex and gender on biomedical research. As you've already heard, I obviously get bored easily. That's why I have 2 jobs, and I did a lot of different things in my career thus far, and I'm going to try to cover a few of those things. I'm not going to talk about myself, but mostly about the field. And what that means is I'm first going to say a few words about why we should consider sex and gender in biomedical research. Why is it important at all? Very briefly about conceptualization. There's a number of talks I've given online, so if you want to go deeper into that, you will find other things that I've talked about online about how to conceptualize sex and gender. I'm going to give you a few examples of what can go wrong, and then I mostly also want to talk about current broader developments in the field. So what is happening? Where are we going? Where do I see new things happening? And then I'm going to talk a bit about implementation. Yesterday evening, we already addressed this a little bit. I'm mostly interested in how do you bring that into practice as well. So how do you work with organizations, with institutions at the teaching level and so forth to actually bring a lot of this information into practice. Here and there, I have some slides that go a bit more into the data level, which will be more interesting for a lot of you. I hope we will. Can you tell me when we have 10 minutes left? So whatever I'm doing, I'm going to try to wind up so we have enough time to have some questions, and I'm around after that as well.
Okay.
Yeah.
Yes.
Just to. So there's a lot of things we can discuss as well afterwards. So I'll give you some food for thought, hopefully. Now, what the slide would be saying is historical path to sex and gender sensitive research. That's just to show you that it's a fairly novel field. So it started in the 60s and 70s with the women's health movement worldwide, I would say. We have a lot more famous publications from the United States and some from the UK, but in Europe, we've had our national women's health movements pretty much everywhere. And a lot of what happened back then was just realizing that there are women's bodies, that they might function differently, that the anatomy might be different, reproductive rights, access to reproductive support, free and safe abortion, anti-conceptionals, and so forth. What you see then from the 80s to the 90s, that we move from a focus just on women's health to a broader perspective on sex and gender, still with a somewhat stronger focus on women's health. But what you see here, and please have a look at the publication for the details, is that you start seeing some institutionalization. So the NIH, for example, in the United States, and then also in the years after, the European Institute for Gender Equality, we fund institutions that actually support this kind of research. And then you see in the 2010s and 2020s, a lot of instruments being developed to incorporate this into practice. So we moved from, I would say, a bottom-up popular movement into some form of institutionalization, into eventually developing also tools for all of us to bring it into practice, because the institution alone is not enough. And that's just to say it's a fairly new field and it's still progressing. And as you all probably follow the news, we have no idea where we're going. And we will see how things develop in Europe and how things will develop worldwide. And that will have an impact on our work as well. Now, Why should we consider sex and gender at all? I mean, of course, I'll tell you because it's important, but I'm biased. So I'll let other people speak. And these are international funding agencies. The first one is the European Commission with Horizon 2020, Horizon Europe. The second one is the Canadian Institutes of Health Research with the Institute of Gender and Health. And the last one is the NIH, which I leave in just for hope. And they had, all of them in the last 10 years, instituted a focus on sex and gender in the research you're submitting. So you're asked to know that. And when they say why you should be doing that, they don't mince words. You see it is really about fairly relevant aspects like reproducibility of the work you're doing, excellence of the work you're doing, and societal value, which especially at the European level has been pushed quite a bit, with the idea that the work we do should benefit the largest possible group of people in society and not just subgroups. So overall, it seems to be a fairly, well, relevant point, and in a certain sense also no-brainer, but it is. What's important, just briefly, at the European level, there's 3 layers that are being considered. One is really gender balance in research teams. So it's like who gets to participate in the work. The second one is gender balance at the decision-making level. And we know that in a lot of institutions, there's quite a gender imbalance when we look at leadership and we look at who's doing the everyday work. And the last one is what I'm mostly going to talk about today, which is really integrating sex and gender into what happens at the country. But what the EU Commission is showing us here is that there is a connection between the context and the content. And this is, of course, something that I have going through my work with everything we do. But it means also that what we do in terms of research, the data we choose, the data we analyze, the way we analyze it, the questions we ask is connected to who we are as people. And of course, we try to be as objective as possible, but all of us come with a personal history. So what we deem important as a scientific question, what we deem scientific at all, what we see as relevant for our patients, for what we've experienced in our lives, connects to what kind of questions we're asking, right? And this is especially relevant at this stage. Just briefly about the terminology. We still see a lot of publications in the biomedical field that mix up sex and gender. So although we've tried to educate people for a while now, and it is fairly well known, we still see a lot of publications that mix this up. Why is it important? Because for the work we're doing, we're looking at both biological aspects and social cultural aspects, and they go together. If I, as a woman, have different symptoms when I have a heart attack, it's a biological question maybe, right? What happens at my cellular level? If the physician that is sitting in front of me doesn't believe that the pain I'm describing is real, that's a gender question. And for me to have the best possible care and possibly not die of a heart attack, I need both. And that means clearly that we need to investigate both of these things because they're interlinked. Most of the research we're doing in the biomedical field is here at the, well, the pointer should be there, at the sex level. So we mostly investigate biological differences because this is also most of the data that we have. So, and in that sense, sex we operationalize as genetics and possibly genetic differences, XX and XY chromosomes, and what kind of impact they have on all kinds of processes. Anatomical differences. Most of us in this room will have been classified as female or male upon birth, right? People look at you as a baby and say you're female or male. It usually works. We have about 1% of the general population where it might not be working because your anatomy is not clearly defined. So anatomy plays a role, and the last one is hormones. Hormones fluctuate. We all produce, apart from some exceptions, which are possible. Some people don't have some receptors, don't produce some hormones, but in general, we all produce all hormones, but in very different concentrations, even within ourselves. So the testosterone level that I measure in someone in the morning is going to be different from the testosterone level in the evening. For people who are cycling, the hormones vary greatly throughout a month. And as we all age, we produce less sexual hormones. So there's huge variations in there. And that's most of the data we have in biomedicine. However, we're seeing that, of course, gender is also very relevant, as I said initially, especially when we have interaction with the healthcare system. That's where gender comes in really. So we need to know more about that as well. Gender is more complex to investigate because it comes from the social sciences, and a lot of the ways to investigate gender haven't been necessarily the established ways we study medicine. Most of the work we do in medicine is quantitative, and we didn't really have a lot of ways to study gender properly. So what we did is, with the way we're mostly proceeding now, is we split it into different so-called dimensions, and we investigate those separately. So gender identity is, are you a man, are you a woman, are you a non-binary person? Gender norms is what are masculinity and femininity in society. So what happens, for example, if you don't conform to that? What does that do with your healthcare provision? Are you being offered better care, less good care? Are you not being offered some things? Am I, as a physician, if I'm not feminine enough, judged as incompetent rather than not sympathetic? And there's studies about that. So does something happen in there with the care? And then, of course, things like gender relations, for example, what happens directly in the interaction between the physician and the patient? So we have many different ways of investigating that. I'm not going to go in the details of that. If you have questions, please feel free to reach out afterwards. And as I said, there's some other talks where I go into the detail. Of course, it's not that easy. So it is really important to know this, to specify what we're doing, because an intervention that I will do in medicine will be very different if I'm targeting sex differences or if I'm targeting gender aspects. So I need to know what I'm investigating. However, the reality is this: sex and gender interact throughout our life course. So we're born as a baby, and then we grow up in a system, first of all, our family, then our community, institutions like schools, universities, workplace, and in a country which has laws, and all of these are gendered. So we are already taught some gender aspects. When we grow up in our family, we will see those in the way workplaces are organized and so forth. All these things interact. So gender has an impact, for example, on risk factors I'm exposed to. And these risk factors impact the epigenetics that you will see in the data. And this can happen either transgenerationally or it can happen in real time. Of course, it's not just sex and gender. Sex and gender also interact with a number of other factors that you might find in large databases that include ability, age, class, race, a lot of intersectional factors. However, all of these together lead to the fact that we have inequalities in health. So sex and gender in themselves, in addition to all these factors, lead to the fact that we have different provision of care, different risk factors, different ability to access certain forms of cures or care, and overall differences in population. Yes, women live longer than men on average, but the healthy lived years are less for women than for men. So you do live longer, but a lot of those years are with some sort of disability. And why is that important? Well, of course, at a public health level, it has a huge impact on healthcare costs, but also on societies overall. Now, just to come briefly back to the data, I think this might be interesting for some of you. You get my presentation afterwards. So if you want to look these things up, there's all the references in there. There have been some attempts to generalize and to harmonize acquisition of data on sex and gender. This is a really nice project under the FIRE framework overall about gender and sex and how you acquire that and how this data can be possibly acquired in a way that is then interchangeable across platforms. Mind, it is about gender identity. So this is there's sexual orientation, gender identity, and different form of recording of sex. But it is one of the most comprehensive way to possibly annotate that in the data. So it might be interesting for some of you. And the project is open and you can access, and they're still developing this. So what can happen if we don't do this? What can possibly go wrong if we don't look at sex and gender differences? I'll have a few things. So the first one, I said, the big agencies tell you it's about reproducibility, right? We want to ideally have experiments that if some other lab does them again, they should give the same results. And one of the aspects that has not been considered for the longest time, and I urge you to have a look at this paper if you have time, is the impact of the researcher themselves. So most of the time, when we do animal experiments, we assume we can control everything. We can control what they eat. We can control how many are in the cage, the temperatures, and so forth. However, it turns out that, well, animals are living beings, and they seem to be interacting with investigators as well. So what this paper showed for the first time about 10 years ago was that actually the sex, the biological sex of the investigator, of the person doing the experiments, had an impact on the behavior of the mice and the rats. So what happened was, depending on whether the investigator was female or male, the mouse would behave differently. So especially the female mice would, in this case, show pain later, depending on whether the investigator was female or male. What was happening is that basically the animals smell the pheromones of the human. And we didn't think that was relevant. We thought humans, well, pheromones are relevant for other humans, whether they find you attractive or not. We didn't necessarily think that it would have an impact on the mouse. Apparently, the mouse smells them too. And depending on what the mouse smells, the mouse will behave differently. So animal experiments that consider behavioral variables, not so much if you do an operation, but if, for example, in the cognition field, a lot of these things involve mice running around in mazes. They might run around differently depending on who's doing the experiment. This has been reproduced by a number of other groups, so it's not something that is just one case. And of course, kind of brought in a whole new variable into the whole investigation, because up until then, nobody really thought that we should even consider who's doing the experiment. We just maybe thought that, you know, one of our PhDs was a bit more sloppy than another one, and that's why we got different results. So no, it's not the sloppy PhD. Maybe it's also the sloppy PhD, but it's not the sloppy PhD. Maybe it's just differences in who's doing this. So of course, it raises questions about what do we need to record, what do we need to know. The second one is the underestimation of hormonal effects. So in a lot of databases, we know that maybe we have female and male participants because they've been asked. We know a number of other things about their diseases, their conditions. We might have data from blood. And most of the time, we don't know if the women participating are taking oral contraceptives, if they are menopausal, or postmenopausal, if they've ever taken any hormone replacement therapy. We usually don't really know. And that limits sometimes our ability to actually analyze the data. Why is it important? What I'm showing you here is data from the Netherlands. This was a study where they were looking for associations between these biomarkers and the likelihood of developing depression. And so what they saw was they had like 3 clusters of patients. And on the right-hand side, you see the male cluster, fairly clear in blue. Then in the medium part, you have women in follicular, luteal, or phase, or postmenopausal phase. And then they had this other clump to the left-hand side, which they only realized was associated to oral contraceptive use, which in fact is a risk factor for developing depression in younger women, because they actually had this data. So if this data hadn't been available, we wouldn't have known what to do with this clump of data. We would have had another cloud there, but we wouldn't have known where to attribute it. Of course, this data was acquired initially when the database was set up. So if there's no awareness in the beginning, once you are there trying to analyze the data, there's nothing more you can do. You just have a clump of unidentified people, which you try to attribute to something here or there. Right? So it is important to consider these aspects early on in data acquisition. And of course, a lot of you work with databases that exist, so you have to work with what is in there, but you also have the opportunity to give feedback on what kind of data you have, what kind of variables would be useful, what kind of variables are missing. And this might be one of those cases where otherwise you couldn't have known something that is biologically relevant, because the number of people taking oral contraceptives in most of our Western countries is quite high. So it is not something that is rare. This is what we mostly associate with sex and gender differences in medicine. So when you look at the press, what you see in newspapers and magazines, it's mostly about this, about the fact that especially women, but also men, depending on what kind of disease they experience, might experience delayed diagnosis. And it goes for a number of things. So basically, if you want to sum this up, it just means that in medicine, we tend to have one image of a disease, one person, one typical patient. And if you not correspond to that, most likely you would experience some kind of delay in your diagnosis, right? That can be a white middle-aged man, but it can also be a woman, in most cases, a white middle-aged woman. And everybody who does not necessarily fit into that picture risks experiencing some kind of delay. That's just the basic core of it. In practice, that means that, for example, in bladder cancer, which historically has been one of the most striking examples, we had huge delays in the diagnosis in women. It looks much better, I would say, in the current statistics, but historically, it was one of the biggest delays that we saw. It was mostly attributed to the fact that women would go to their GP, say that they saw blood in their urine, that they have symptoms. And first of all, we think they have a urinary tract infection, which makes sense because clinically speaking, it's the most likely diagnosis. So it's not wrong per se. However, if they keep coming with these symptoms and they don't respond to antibiotics, maybe it's time to start thinking in a different way. The problem that is in addition to this is that the bladder wall is anatomically thinner in women than in men. So by the time these women get diagnosed with the tumor, a lot of times it's already more advanced because in addition to the delay, they also have an anatomical disadvantage. So they have a double situation that then makes their prognosis a lot worse. The second example is, for example, asthma. So when we think about asthma, when we think about symptoms, most of the time what we will think about is an asthmatic attack, right? When you think about when people have asthma, they can't breathe, they have the wheezing, typical thing. It's very common in male patients, especially in young boys. It's not that common in young girls. Young girls might not have any wheezing at all, have no episodes of that sort, and actually have chronic cough that is mostly nocturnal. So it took many years, now the guidelines have been changed. It took many years to realize that no, they didn't in fact have an infection. It was in fact also asthma, which again leads to delayed diagnosis, which as we know in asthma is not very favorable because you want to start intervening early on, as early as possible. But of course, it doesn't just go in one direction. If we think about osteoporosis, the picture we have in our heads is a postmenopausal woman. That's the patient with osteoporosis, right? That's the person we screen in our healthcare systems for osteoporosis. And yet, 30 to 40% of men over 65 also have osteoporosis. So it's not rare. I could count you over 65, and 1 in 3, if not 1 in 2, will have osteoporosis as well. And yet we do not screen yet. We might probably change. A lot of societies are working towards that. But that also means, that's the image. You don't even get screened for it. And a number of novel therapies hadn't even been trialed for men with osteoporosis. Only been trialed for women with osteoporosis. Same thing goes for autoimmune diseases. Autoimmune diseases are more common in women, apart from a few exceptions. Most autoimmune diseases are more common in women. And again, what we see here is that a lot of times an autoimmune disease is not suspected in a male patient until much later, and the diagnosis is usually later. And here we see the same thing that we saw for women with bladder cancer. A lot of times the disease is already more progressed and the prognosis is worse anyway in the men. So overall, it is even worse due to the fact of the delayed diagnosis. You have a delayed diagnosis, you have a more fast progression, and so overall you have a worse prognosis. And then we have this, which I always hope I could eventually take out, but somehow then long COVID happened and I decided to leave it in. For diseases that are difficult to diagnose, and the example here is multiple sclerosis, because multiple sclerosis a lot of times starts with some symptoms, and then you might not have any symptoms for a while, and then you have symptoms again, so it's tricky to diagnose at times. And this is a study that done about 15, 20 years ago, where they asked patients with multiple sclerosis which kind of physicians they've seen before they eventually got the diagnosis. Well, a lot of times you're sent to all kinds of specialists until eventually you find out what you actually have. And interestingly enough, a lot of the men had been sent to some orthopedic surgeon because we assumed that's some kind of physical disease. And a lot of the women have been sent to psychiatrists. Now, some of the women had also been sent to orthopedic surgeons, but none of the men had been sent to psychiatrists, which maybe says something about our assumptions as physicians as well. And as I said, if you think about long COVID, we had similar practices again, where initially it seemed to be a disease of stressed women who had COVID. And now we know it's a whole cluster of symptoms and it's actually a disease entity in itself. Now, apart from that, what happens now where, of course, we have AI in quotation marks that is going to solve everything, is going to cure cancer and solve climate change. And of course, it's also going to solve all our medical problems and make doctors obsolete. So we have chatbots, for example, based on algorithms that will tell you what you have as a disease. So the way this works is you tell the chatbot what your symptoms are, and then the chatbot tells you what you could have in terms of disease, right? So if you tell the chatbot, I'm a 56-year-old smoker, smoke 10 cigarettes a day, and now for the last hour, I've had a painful left arm, and now I feel sweaty and sick. And you tell the chatbot, I'm a man, this is what you get. Number 1, you have a pericarditis, which is an inflammation of the heart. You should go to the ER. Number 2, you have unstable angina, also heart condition, you go to the ER. Number 3, you have a stomach flu, you can go to your GP tomorrow. Number 4, sorry, you have a panic attack, stay at home, breathe. And number 5, you have a heart attack, go to the ER. So I assume that if you're a man, you're probably on the way to the ER. Okay. If you tell the chatbot you're a woman, this is what you get. Number 1, you have a panic attack, stay at home and breathe. Number 2, you have depression. Which you will probably have if you actually had a heart attack and didn't go to the hospital. Now, years ago, when Twitter was still Twitter and not X, you could actually use that hashtag and find a lot more examples of this nice chatbot, which for undeclared reason never made it to market. because I guess selectively targeting women might not be a good business model. But I don't think that's what they were trying to do. I think they really started with the best intentions, but what did they do? They trained their model on historical data, right? And I just showed you what historical data looks like. That basically there's delayed diagnosis depending on what you have, depending on who you are. And of course, if you train your model on that, your model will reproduce exactly the same thing that we've done historically wrong for 20 to 30 years. It's also the reason why at Amazon, your curriculum, if you're a woman, might not be selected, because it's also trained on whatever has been there before. So of course, it means that we need to do something about the data. First of all, know that there might be bias in the data. Now, the last one, and this is the one you mostly find in the news, how is it with clinical and pharmacological data? Why is it important to consider sex and gender there? Well, this is studies from the 90s, but it's a very nice example of why it's important to look at sex difference. So this is a study to investigate the safety of digoxin, which is a medication for heart failure. And when you have a new drug that you want to go to market, of course, the first thing you want to investigate if it's safe. So the first thing you do is a safety study where you compare digoxin with placebo, and you see how patients are doing. Right? Ideally speaking, you don't want them to do worse on the drug than on the placebo. Ideally, you should do better. It was a very large study with almost 7,000 participants, 3,400 in both groups. And you see the two curves pretty much overlap. So we're happy and it looks fairly good, right? We can give it. So then digoxin was used, it was approved, and it was used quite largely. And a lot of women started getting side effects, a lot more than men. So 5 years later, and kudos to them, the same group picked up the data again and said, well, maybe we should disaggregate it by sex. Yeah, why not? We have the data. Let's have a look. So what they did was this, and what they see, so basically for the curve, just briefly, it down is bad. It's closer to the ground. Those are the patients that did not make it. Up is good. So we start at the lowest level with the men on placebo, who did a little bit better than the men on, a little bit worse than the men on digoxin. So digoxin was effective for this group. Prolonged the life expectation a bit. So plus for the men on digoxin. Then we have, on the lower of the two, the women on digoxin, and then we have the women on placebo. So at this fixed concentration, actually the women on placebo did better than the women on digoxin. So you will wonder, how could we get this graph from this data? The thing, right? Well, relatively easy to explain in basic statistics. The women participating were 25%. The men participating were 75%. So if you have a little advantage in the 75% and a bigger disadvantage in the 25%, statistically speaking, you put them all in one big bin, you get this. And I think this is a fairly convincing slide and data set to show why it might be helpful to at least look for potential differences. Now, did this get much better? Yes and no. We're doing better on enrollment, and we wanted to know how we're doing on analysis. So during COVID times, together with colleagues in Denmark, we actually looked at COVID trials, and we looked at all the trials registered between January 2020 and 2021. And we wanted to know, first of all, how many reported sex and gender as a possible criterion for recruitment, and how many of them said that they would consider sex and gender upon analysis. There's the data. About 1 in 5 said they will consider it explicitly as a recruitment criterion. About 1 in 20 said that they will consider it upon analysis. Of course, none of these studies went through. So it was a moment where thousands of trials were registered because everybody was trying to do something, and not everything that's registered actually goes to trial. So this is much more messy, I would say, as an initial picture than what really happened. So we also looked at only the pharmacological trials that were published in January 2021. So those are the ones with the strictest guidelines. And even there, were the ones with the strictest guidelines, only 1 in 5 actually reported some sort of sex disaggregated analysis. And mind you, this is a disease where all media kept bombarding us about the differences between women and men. So that it cannot be a problem of awareness here, because this is one of the few cases in my career where I was like, I don't have to tell people, they're actually coming to me. So it's one of the first times that people actually thought that maybe looking at sex differences might be relevant, and still only in about 1/5 of the studies it was considered upon analysis, and we actually had this data. So unless you regulate things, probably not everything happens. And that's also why we're mostly in the implementation field for now. A few thoughts about broader developments that are happening in this field. It might be interesting. Some of these might be interesting for you. So first of all, I don't expect you to read this. I have the publication down there if you're interested. One thing that is happening, and that's interesting for the ones of you that work with large data sets, is sex contextualism. So with the funding agencies asking to consider sex in the analysis and to consider it in the projects, a lot of people are doing very simplistic comparisons between female-male animals, female-male participants, that's it. And what this paper argues, and in general is part of a larger movement, as I also showed you initially, it's more complex than that, right? So this doesn't happen in isolation, and a lot of times there are many additional factors that play a role. So especially the ones that work with large data sets, there's a lot of methodologies. And if we did not use that kind of methodology, we wouldn't have gotten the answer. So if we want to know in general which gender dimensions impact the quality of life of people with Parkinson's disease, quantitative methods are fine. You can use surveys, you can use those to delineate. If you really want to know how gender impacts the experience of Parkinson's disease for patients every single day, you need to do qualitative interviews. They need to tell you what it is like. You cannot acquire this comprehensively with a survey. And if you actually want to know what they would like in terms of care, so what people with Parkinson's disease specifically would like for their care and how do you make that gender sensitive, you actually have to develop it with them. So you need to do co-design techniques. And so what that showed us was with different methodologies, we got different answers to different things, and gender was something different or different angles in different types of studies. So that's why I say you need a triangulation and you probably need different methods to come at the core of how this impacts care. Publishing requirements have increased. In most cases, when you now try to submit a paper with Springer Nature, with Elsevier, with Wiley, you'll probably be asked if you have considered the SAGER guidelines. So the SAGER guidelines, that is Sex and Gender Equity in Research Guidelines, published in 2016. It's an open, no, I don't have the picture. It's an open access publication. It basically contains a number of checking points that you can look at and how could you represent adequate sex and gender reporting in your paper. So I urge you to have a look at that because a lot of these publishers will also ask you to use that or actually have a box where you will say if you used it. So where are we overall? I would say we're somewhere here. What I'm talking about is not fringe anymore, so I don't get stared at as I used to get stared at 20 years ago, but it's also not something that is institutionalized. So it is not something we have it at the funding agency level, at least to a fair degree and depending what you're looking at. But in a lot of the practices, bless you, in a lot of the practices we don't really have it at the institutional level. And I'm going to show you two examples of what that means at the institutional level, because of course there's a number of driver inheritance. My last slot, implementation, which is what we're trying to do and what do we see. Now, whenever you have a new thing that you want to implement, and in this case, sex and gender sensitive medicine, you are confronted with a number of issues that you have to deal with. Well, first of all, how is the innovation? And that means how well does it fit in existing systems? Do you ask people to do a lot more than they usually do? Is it very different from the way people have done things before? So that. Second, that what you then meet is institutional resistance. We've always done it like this. It was fine. Why do we need to change anything? Right? Why do we need to make the effort? There's a lot of other things we need to do. Why do we need to do that? Then, of course, there's personal experience. I've done it, and all of a sudden, I found really interesting thing in my data. Now I'm going to do that. Or I haven't done it before. It never changed anything. Why should I do it at all? And then, of course, there's also like when people start looking at you weird, going like, you were a great immunologist, and why do you do that weird stuff all of a sudden? That's the peer perception. I got that, by the way. And so that's, of course, a lot of things that come together when it comes to implementation. The barriers, they're not specific to this, but there's some layers that are specific to sex and gender. Overall, organizations are very resilient. What that means is organizations don't like to change. We have some organizations that pride themselves on changing a lot, and then maybe you have chaos, but organizations that have existed for a long time, and universities tend to be like that, like to preserve existing structures and don't want necessarily change, right? And that means this is something new, it's a new way of thinking, a new way of doing it, we don't necessarily want it. There's a competition for power, for funding, for visibility, for agency. If you do this, you cannot do something else maybe, right? The money goes into this, goes on to something else. There's people who are more powerful that think it's nonsense, so you're never going to get it through, and so forth. It might not match your organizational priorities. if your organization now all of a sudden is decided to invest a number of millions because all hospitals now need to do AI, there might not be much money to do diversity or sex and gender. Not saying that one is more important than the other, just saying there's organizational priorities that are moved by things that might be completely disconnected by what you're doing, right? They might be connected to other levels. There might be a lack of capacity, influence, visibility, and power. The people that have the expertise in this field, there's more and more, but it's not that many. So you might not have the capacity. You might simply not have the people in your organization who can do that. They might not be visible, or they might be a PhD student who all of a sudden thought that is great, but in the whole food chain of your organization, they're a PhD student. Right? There's insecurities about the topic of sex and gender, and that's a very diplomatic way of putting it. Of course, it is very often still perceived as a political topic, and there is a political dimension to it. But there's also a lot of issues about what am I doing? Do I do this right? It's not always bad in terms of like, I don't want to do this. A lot of times it's also insecurities. What am I actually measuring? How do I do that? Do I bother someone if I ask them? A lot of times I get questions about questionnaires. If we do this questionnaire with 70-year-olds and there's a question about gender identity, will they stop filling it in and we have missings because they're bothered by the question? Answer is no, but still. So there's a lot of insecurities. And of course, the topic is perceived as emancipatory, as woke, as related to women only, as political, you name it, you know what I mean. So that also means that still, even when we look at sex differences in mice, it is still has this kind of aura around it. So it is fairly easy to be put in that. So what can you do? And these are two things that we're doing in my group in Bielefeld. We're mostly focusing on implementation at the curricular level. So we have a new medical faculty. We're developing a new curriculum. And so we have the opportunity to experiment with what it means to incorporate that into a new curriculum. I would say the reality is you would like to have focus on sex and gender at the training level for your medical students, for your PhD students, and so forth. So it should be something that's incorporated in the mandatory curriculum. And the way it works, usually, and the way we're making it work, you have lectures from experts. And ideally, and what we see a lot with our students is we have a lot of requests from students. So we have a bottom-up movement that requests it. And with that together, you can actually achieve that. We just published this, which is a theoretical underpinning for the implementation of sex and gender-sensitive medicine at the educational level. So why did we develop this? Because there were no real models. And this is based on an existing model for gender responsive evaluation, which used to be applied mostly in the public health field, but it had never been applied at the education field. And what it basically shows you is there's different stages and different steps you're in, going from gender discriminatory, gender blind, gender sensitive, gender responsive, and gender transformative. So it's like an incremental model that shows you how well is sex and gender integrated in your lectures and what does it do with your learners. We did this, first of all, because we needed a theoretical model, but we also did it because it allows us to map our curriculum. So in order to convince everybody else in the faculty who's not doing this, we need to have a baseline about what is happening. So we use this model to analyze all lectures in the first 2 years done by all of our colleagues based on content, language use, imagery, and stereotyping and discrimination. And then you get these kind of curves that basically show you in how far is sex and gender incorporated in the content, in how far is it incorporated in the language use, and so forth. This is a great instrument then to go talk to people, and not by telling them you're doing really badly, but by telling them, listen, we can help you in doing better. And so we're kind of offering a number of services where we help them with literature search, we help them with looking at their slides and kind of tell them how they can make them more inclusive and so forth. Of course, it's not just that. We also have another layer, which is the hidden curriculum. And the hidden curriculum is everything that is, as it says, hidden and not explicit. So there's the explicit stuff that I'm telling you now, but there's also the implicit stuff of me being a professor for this and the way I behave. And you, if you're at the beginning of your career, see me doing this in a certain way and get certain ideas about what I'm doing here. I'm not saying anything about myself, but still, only by being here and talking about it, I'm conveying certain things that are hidden. And that goes for the entirety of the medical curriculum, which means, for example, when we do skills lab training, do we have mannequins that are female and male? Do we have different skin colors for venipuncture and so forth? Do you have that kind of diversity represented? Which kind of language do we use? Which kind of images? What kind of slides? Do we always have male surgeons and female nurses on our slides when we talk about, how we do surgery. And then, of course, the structural and institutional levels. Who gets access? Who's teaching at all? Who has access? Do you have mentorship? How do you create a safe learning environment where everybody feels welcome and feels welcome to ask questions actively, right? And how do you make your institution more inclusive? So that's another layer to keep in mind. The second one, and I'm coming towards the end, is the guideline development. And here I mean clinical practice guidelines. So what I showed you was more of an institutional level. So what can you do in teaching? And this is more at the guideline development. So there are, at the European level, clinical practice guidelines, right? So in theory, clinical practice guidelines are the highest level of standardization of how clinical care should look like. If you have a certain disease, there's probably clinical practice guidelines, either national or European, that recommends what to do and what not to do with you as a patient. Now, we were interested in seeing how sex and gender is represented. And so we looked at, let me go to this first. We looked at the European clinical practice guidelines that were published between 2012 and 2022. And yes, that's 11 years. And we wanted to know how sex and gender was represented overall. Is it present overall in the text? So does the guideline say anything? But some guidelines say, well, it's important in the introduction, but then you don't find anything in the practical recommendations. Do we see it as a representation in the suggestions? Sometimes there's non-binding suggestions in these guidelines. Or do you see it in the graded recommendations, which are the evidence-graded recommendations that actually influence clinical practice? We identified 325 of those clinical practice guidelines, which contained more than 14,000 individual recommendations. And a bit reminding of what I told you about COVID, of these 660 addressed sex and gender topics overall, mostly in the form of pregnancy and fertility, and less than 1% addressed sex and gender beyond reproductive. And if you look at the keywords that we used, you see some of them down there. The word that is most common in the field of sex and gender, what is mostly associated with sex and gender, is still pregnancy. So you see that's the biggest bubble for all of them, and that beats all others by far. Even more than women, even more than female, and so forth. And by the way, intersex and transgender were mentioned less than 10 times. Now, what does that mean? It has several reasons. One is representation. Sorry, the quality is really bad here. Anyway, we have a nicer version of that. But anyway, so still, if the quality is not very good, you can imagine what the purple bubbles are. Those are committees that are predominantly made up by men as participants and as committee members. And the orange and reddish ones are the ones where women are predominant. And then you have a middle field. So, of course, representation plays a big role in the committees, but it also plays a huge role in the source data. So you can have a very well-intentioned committee that wants to really develop sex and gender sensitive guidelines, but you might not have the data to do that. And that's a different study that we did with colleagues in France. We published last year, where we looked at the baseline data that were used for the 2019 European Society of Cardiology guideline for chronic coronary. There were 188 articles that were used for this database, ranging from the 90s to 2019. Overall, that's more than 1.5 million study participants. And you see a number that you've seen before. About 25 to 27% of these participants were women. I remind you of the digoxin study where, if you have certain representations, you might not even have the information to then make inclusive recommendations. In connection with what I told you about the EU in the beginning, that the context determines the content, if you had a woman as first or last author on those trials, your likelihood to having more women participants in the study increased. So there is a connection between who does the studies and who's included. But that's just to say, even if you have the most well-intentioned committee, if the data is not there, there's nothing you can do. What you can do as a committee, and some of these committees did that, is actually pointing out exactly where the things are missing. So that's the one important step you can probably take in kind of making clear what's missing, but it's not always there. Now, conclusions with an L. Sex and gender sensitive medicine is a dynamic field. And as I showed you in the first historical slide, and that is true for a lot of things happening, there's many different approaches. And sex and gender sensitive medicine means many different things to many different people, sometimes not agreeing on what it means. But in general, we're seeing growth and attention to it because we're seeing that it has a clinical impact. Not including the sex and gender in your clinic, in your process, might just reduce the quality of your data, the reproducibility, as we've seen, and the societal relevance. So it should ideally be included from the design throughout the analysis, through the publication. And we would really wish that those disaggregated analyses were made available to people, which a lot of times is the problem. Because maybe you did the analysis, you didn't find any differences, which is also fine, but make this data available, make these analyses available so that somebody doesn't have to repeat something which may be overage. We see that new methods are being developed, and that's something where I'm happy to talk about if anybody's interested, because we're also working on this. A number of groups are working on this to measure sex and gender, because we need to improve on that. And there's a lot of pitfalls and different ways and new techniques of doing that. And so it's a very dynamic field. And I hope that really we will come up with innovative ways to especially measure gender to make it more visible and relevant in the clinical practice. Regulation increases the availability of information. So the funding agencies asking people to look at sex and gender increases dramatically the number of data we have right now. But of course, we also need to do something with it. So that's the next step. But we have seen really a much steeper increase in availability of data. Implementation, as I showed you at the end, needs to account for structural factors, and those can be at the macro level, that can be at the meso level, that can be at the micro level of your organizations. And sometimes you cannot change those structural factors, but it's important to, first of all, know them, take them into consideration, and highlight their impact so that you can overall change this and possibly implement this at a cross-cutting level. And with that, I thank you very much. And that's it.
Thank you so much, Sabine. And we have time for some questions. Some are online. Yeah, let's start here in the audience. Any question? Questions? So maybe we can read some of the chat. Okay, so question from Paula.
Yes.
How much these guidelines are being applied or used, and more importantly, audited for consistency in research grants or consortium, for instance, like a European funded project? It looks like the sex and gender perspective is mostly and merely a ticking box requirement.
Now, I think it's different levels, because one thing is the guidelines, and one thing is the funding practices. Right? So for the guidelines, there are no rules for incorporation of sex and gender at this moment in time. And we're actually, what we hope to do, so what I showed you now is still hidden and embargoed and currently under review. We hope it will come out soon. And what we actually want to do with this data is work with some of these societies that make the guidelines to see how can we incorporate that into their processes. So this is going to be future. When it comes to the EU level of how this is monitored, you get the money initially when you write it in there, and then it's not really monitored that much. I will put it like this in diplomatic terms. What usually happens is that when you're at the midterm, you might get some feedback, and that also depends a bit on who's reviewing it. So it is, theoretically speaking, up there. We also wrote some new rules in the terms of gendered innovations of how you could incorporate that in the monitoring process. So there are, I think, fairly decent recommendations how to incorporate it in the monitoring process, but then we had the Draghi report, which tells us that everything needs to be leaner and faster and less bureaucracy, which has a lot of merit. I mean, it's true that it's a hassle when you write a European grant. There's a lot of things you need to do, a lot of questions you need to answer, a lot of bureaucracy. But it's also true, the question is now what is being cut and what is being streamlined and what is not. And that, of course, reflects some of these priorities. So as far as I know, They haven't changed the auditing process. So what that means is at the midterm, you might get a question about it, but then nobody's going to stop the flow of money, and we all know that, once you got the grant, and it's not just for this, for a lot of other topics as well, if you can argue well enough of why you deviated from your initial protocol, most likely not much will happen, right? Unless it's catastrophic. But most cases, we can articulate why we deviated. And so in a way, it's also difficult to say, well, why should this be different for sex and gender or ethical aspects or stuff like that? If for the functional aspects, they also mostly let it through. You might be grilled on it a little bit, but in principle, most of the time. So I think monitoring is a question mark, and some projects do well, some projects put it in and don't necessarily do it. It is true that, and I would argue that there is some merit to the fact that people at least need to think about it. And I think that's already a step forward, because in the past you weren't never asked explicitly to do it. And so I think that even the fact that you need to think in how far can this apply to my data is already a step forward, because all of a sudden you need to consider, well, is it important at all or is it not? And I need to reason of why this is important. And since it is flagged, I have to do it. Sometimes even just that and saying, for the sake of it, it might give us another small publication. Let's just do it. Look at sex differences. I think the most relevant changes of mind I've seen were in people who thought this is nonsense, and then they were forced to look at their data and they actually found something that was super interesting, or that at least they never thought was there. And all of a sudden they started doing it. So I think in those terms, it's one of the best ways, because people love their data, right? It's like my baby, we built this project. This is so important. Finally, we can analyze. And so finding it in your own data is, I think, one of the most convincing ways to get people there. So even if you can articulate some of those, it's already a step forward compared to what we had before.
Yes, please.
Yeah.
I've got a question about the complexity of the gender category and the idea to try to figure out how to make it dynamic and but
That's a minor. Okay.
Like the bug, but the foot that I want to.
they're gonna hear me then.
Yeah, otherwise you turn on, right? They heard me, so.
So my point is, like, one of the slides was showing that's how the woman, the sex, was like not representative. There was more like the fact that there are contraception and different stage of menopause. So I mean that this category of sex, woman, man, is not good enough to capture the complexity of what's happening in the body. But now I've got the impression that trying to have the gender, trying to capture everything that is complex social interaction will kind of go in the same direction, having the problem we have right now with sex, because you will have the, I don't know, the more power relationship, the social class.
Yeah. So today I didn't talk too much about that because I thought that someone would fall asleep. But when you decide how to measure gender, it's also not a one size fits all. So what we usually recommend, and what we try to do in our studies as well, is kind of pick what kind of dimensions of gender around it. You don't always need to do everything. You don't always need to do the whole battery. In some studies, it's exploratory, that is interesting, but it's also a question, which kind of gender dimensions do you think around? So maybe you acquire only that. You only think that there's a level at the interaction with the physician in the consulting room, so you're mostly interested in gender relations. Maybe gender expression, you're not interested that much. Maybe when it comes to norms and roles, you don't need that as much. You can boil it down. So I think in that sense, it's especially for gender also important to even start thinking about what to do. Because right now, when we look at the papers, and we did that a few years ago, in most papers, it's not even clear, even if they say they analyze gender, we don't know what people are doing. And so that's why I also focus a lot on this methodological clarity, even for sex. If you use sex to analyze your data, what kind of measurement has been done? Is that anatomy, sex assigned at birth? Maybe it's great, but a lot of men with Klinefelters that have multiple copies of the X chromosome don't know that they have Klinefelters until in their 30s, they try to have children, and all of a sudden somebody does a karyotype and they find out they have Klinefelters. So the sex assigned at birth is male. They live with that for 30 years. And then all of a sudden, genetically speaking, they would be intersex, right? So even in that sense, having that clarity to say, even when you do sex-specific analysis, how have you done this? What are the limitations and so forth would be worthwhile? So I think we really need for this field overall much more clarity in what's being analyzed. That goes for sex, and it specifically goes for gender, and kind of singling also out, what are you looking for? Are you trying to do an intervention? Are you trying, so what is it? Do you want an intervention with primary care physicians, for example, that you want to educate on being more inclusive in their language, for example? So what kind of dimensions do you need for that? You might not need everything, but some things you need. What is your best technique on doing that? Is survey the best way to acquire your data? Or maybe do you need qualitative methodology? So I think what we really need in here in all of this to make the field much better and more reproducible is more methodological clarity overall. So we see an increase in data, and that's why I think that the critique of the sex contextualism, which sometimes I think goes too far in what is applicable, but I think the reasoning overall that not everything is neatly boxable in two of these boxes and then we're done, but the reality is much more complex, makes it much more difficult, but then much more applicable. So what we saw is actually tailoring it down, especially in the study we did on Parkinson, in smaller groups that were much more specific, allowed us to develop interventions that actually work for that group. They might not work for the whole of the patients, but it's difficult to develop those interventions anyway. But we did specifically investigate what worked for a specific subgroup, and in that sense. And I think what that means overall is I think we really need to be precise in what we do. We need to be precise in how do we measure things, what do we need, and how do we provide. So I totally agree with what you're saying. It is complicated, but I don't think you need to do everything all the time, but you need to really invest the time in thinking what is helpful for the work that I'm doing and then select the questionnaires that might work.
Yeah. You have said at least 2 times that there is more data. I wonder why did you say that there is more?
We see an increase. So if you look at, we looked at some of the trends of publications that actually look at sex and gender differences over time. And we've seen already that in the, I would say, starting from the early 2000s and up until the mid 2010s, we saw a dramatic increase in publications that actually incorporated an attention on sex and gender. So that there's simply more data being produced in the system. Not all of this is good, not all of the analysis is good. And we see more attention towards actually collecting data on sex at least. Because, for example,
the database is disappearing. And we also see people that don't want to say what is a sex.
So I think, I mean, let's put it like this. What we're seeing right now is, first of all, unprecedented. And I think we're a bit of the canary in the coal mine. So what is happening, we start with appeasing the political base by saying DEI and sex and gender is bad. And 2 months down the line, I just gave a presentation about this 2 weeks ago. 2 months down the line, it's science overall, right? And we don't get funding for anything. And if you think it's everything that fell under DEI, if you look at the terminology that is not allowed anymore, you cannot do public health research anymore. You cannot do clinical research anymore. All of these terms mean patient-centered care. So in that sense, the problem is much larger. And we, as I said, this is a bit of the canary in the coal mine, I think, but we will see a movement in that sense in general. The question is, I think, first of all, what happens with data in Europe? What needs to be maybe migrated? How will the Commission generally deal with that? For now, we see all kinds of promises for keeping things, at least in the interest of science. But yeah, I think we're seeing a movement in general, which might actually reduce the amount, not just about sex and gender, it might reduce the quality of the data overall to the detriment of patient care. I think at the end of the day, what we see at the public health level, at the clinical level, the more specific we know, the more specific we can tailor and more contextualize our care, is the better it is for the patient. And it doesn't always mean we give them 5 more drugs. Sometimes it just means in their context, this is what they need, and maybe they need 2 drugs less, but they need more of social support, right? So it can be in any direction. But yeah, we live in interesting times. So, yeah, that was very diplomatic, wasn't it?
Okay, one last question from the chat. This is from Maria G. Thomas. Despite the long-standing legal and ethical obligations, clinical research continues to neglect sex and gender data disaggregation. In this context, how crucial is building alliances between organizations to push for real enforcement of gender-sensitive legislation?
Of course, I'm all for alliances. I mean, and I think that goes for everything. I think in that sense, it goes for this as it goes for anything. Building coalitions. I mean, some people are fairly good at building coalitions. We're not always very good at building them in science, and also not for some societal topics that might be more progressive. We tend to fight with each other more. But in general, I think if you build, and I think that's the next step as well at the European level, how can we reinforce each other in maintaining also standards of science? I mean, I'm looking at a very specific aspect, and of course, I look mostly at that aspect. But if we want to preserve the quality of the science we're doing, if we want to preserve a lot of guardrails we're trying to put in place to make science as applicable and possibly a bit less discriminatory and so forth, I think we will need to band together in different ways than we're doing right now. We were fairly complacent, I think, for a long time because we were doing fairly, I mean, yes, of course, there's a lot of problems in the system. We were doing fairly well, I think. And now all of a sudden we wake up to this, and most scientists don't see themselves as activists at all. It's bad to be activistic. And I'm afraid the boundaries between science activism and being a scientist are being blurred, and we all need to become a bit more activistic if we want to be able to keep doing the work we're doing for the greater good of society. So, yeah. The call to activism.
Okay, and with this call to activism, we thank again Sabine.
Thank you.